Hello, newbies. Welcome to the exciting field of stroke. My name is Igor Rybinnik, and I'm a vascular neurologist at Rutgers Robert Wood Johnson Medical School and the Neurology Clerkship Director. Over the next 90 minutes, you'll become a stroke neurologist, managing patients with various cerebrovascular emergencies. So keep your hands and feet inside the vehicle at all times and have fun. I have no relevant conflicts to disclose. So the objectives of this talk are to review the vascular anatomy and vascular syndromes, to discuss the diagnosis and management of acute ischemic stroke, to review the 5 mechanisms of ischemic stroke with a specific focus on diagnosis and stroke prevention, to discuss the diagnosis and management of acute hemorrhagic stroke, and to review the 3 mechanisms of hemorrhagic stroke with a focus on diagnosis and prevention. So before we get to the fun stuff, we do have to review cerebrovascular anatomy. Yeah, I know what you're thinking. That is so last year. Second year of med school called and wants its pile of information back. Unfortunately, anatomy is still important for everyday stroke care, and we have to crawl before we learn to walk. Pretend this patient is looking directly at you. I haven't chosen this view by chance. You'll see this view in various vascular studies. You can see the arch of the aorta on the bottom of the screen, giving rise to anterior and posterior circulation vessels. Common carotid arteries typically arise from the brachiocephalic trunk on the right and aortic arch itself on the left. They bifurcate into external carotids with branches in the neck, that's how you know they're external, and internal carotids that ascend all the way to the brain. In the back of the neck, vertebral arteries arise from subclavian branches of the aorta and supply the posterior circulation. So far so good? Great. Now let's take a look at the intracranial vasculature and the circle of Willis. The 2 vertebral arteries we spoke about are visible here with an important perforator called posterior inferior cerebellar artery, or PICA, which, you guessed it, mostly supplies the posterior inferior cerebellum and lateral medulla. Vertebrals then join together to form a basilar artery, with major branches including the ICA, or anterior inferior cerebellar artery, the SCA, or superior cerebellar artery, and at its tip, the basilar bifurcates into posterior cerebral arteries. It sort of looks like a palm tree. From the posterior circulation, posterior communicating arteries connect PCAs to internal carotid arteries, and the anterior circulation is basically comprised of ICAs, which bifurcate into middle cerebral and anterior cerebral arteries. And anterior cerebrals are in turn connected by anterior communicating artery. There's quite a bit of variability in the vasculature, and only 1/3 have a complete circle of Willis. Whew, you're still with me? And now for the pièce de résistance, vascular territories. You can see them coming into view as I scroll. You can actually refer to the legend on the right side of the slide to see which vessel corresponds to which color. So the medial frontal lobes are supplied by the ACAs. Medial frontal lobes are important for contralateral leg control, motivation, and the memory circuit. So as you can imagine, ACA infarcts cause abulia, an unmotivated state, contralateral leg weakness, and amnesia. MCAs supply the vast majority of the hemispheres, and occlusion of these vessels causes quite a bit of symptoms, including contralateral hemiparesis, face paresis, gaze paresis, sensory deficits, field cut, and in non-dominant lesions, neglect, and in dominant hemispheric lesions, aphasia. With those symptoms, you can throw in dysarthria, which is non-localizable and can occur with any damage to the motor tracts, and difficulties with skilled movement called apraxia. Now, PCAs supply the thalami, so-called the switchboard of the brain, as well as occipital lobes and large parts of the midbrain. So it's not surprising that PCA territory infarctions can be very diverse. They can cause sensory loss on the contralateral side, but also field cut, hemianopia, occasionally neglect if you damage the non-dominant thalamus, and transcortical aphasia if you damage the dominant thalamus, and behavioral abnormalities. The patient can look frankly psychotic with thalamic damage. Now, as we go lower, if the midbrain is involved, and midbrain here is pictured in blue, it looks like a head of a Mickey Mouse, you can get contralateral hemiparesis from crus cerebri involvement, ipsilateral third nerve palsy, and contralateral ataxia from red nucleus damage. The basilar artery supplies, wait for it, the base of the brain. Well, mostly the pons and some anterior medulla to be precise. So unsurprisingly, it can actually cause contralateral hemiparesis with or without facial weakness, hemisensory loss, intranuclear ophthalmoplegia, that's when both eyes are not moving in synchrony, and that's from a medial longitudinal fasciculus damage. It can also cause ipsilateral symptoms, including horizontal gaze paresis from pontine paramedian reticular formation damage, ataxia from damage of fibers that are going to the cerebellum, lower motor neuron facial weakness from cranial nerve nucleus of 7 damage, facial sensory loss with cranial nerve nucleus of 5 damage, as well as nystagmus. Next, SCA. It supplies the anterior superior cerebellum, it's all in the name, and infarcts, occlusions of that vessel can cause ataxia. Lower down, you see anterior inferior cerebellar artery, ICA, pictured here in light blue. Now, it mostly supplies the cerebellar peduncles, so ICA territory infarcts are very similar to SCA infarcts, causing ipsilateral ataxia. However, ICA actually gives rise to labyrinthine artery, which supplies the inner ear, and occlusion of ICA can cause ipsilateral hearing loss. And finally, pica, pictured here in purple. Pica supplies the lateral medulla and the posterior inferior cerebellum. So, occlusions of pica can actually cause cross signs. So you get contralateral hemisensory loss from spinothalamic tract damage, but you can also get ipsilateral facial sensory loss from cranial nerve nucleus of 5 damage. You can also get tongue deviation, a Horner syndrome from sympathetic damage, and ataxia from cerebellar damage. You also get bulbar signs, the so-called for the bulb, and bulb is the medulla, so you can get dysarthria, dysphagia, hoarseness. Lower down, perforating branches of the vertebral artery supply the medial medulla, and stroke in that region can actually cause hemiparesis due to pyramidal damage. I hope this was a review, and now you're still confused, but as Enrico Fermi puts it, hopefully confused but on a higher level. Otherwise, you may need to rewatch this segment in slow motion. Also, consider pausing that Netflix show that I know you're simultaneously watching while watching my podcast. Okay, so now that we understand the vessels involved and the symptoms their blockage may cause, let's jump right into a case. So we have a case of a confused man. He's a 74-year-old man with hypertension, dyslipidemia, coronary artery disease, who develops acute confusion, left facial droop, left-sided weakness while driving his car. He's able to pull over to the side of the road, and bystanders who witness this event actually call the ambulance. He arrives to the emergency room 1 hour after symptom onset. He has no headache, and he's able to protect his airway. You're examining him in the emergency room, and you notice that he's alert, awake, he's oriented to place, person, and time. He has no aphasia, but his speech is slurred, he has dysarthria, and profound neglect. He doesn't even recognize that he has left-sided weakness. He also has right gaze deviation, and no matter how hard you try, you can't get him to cross midline with his eyes. He also has left field cut, left facial droop, and flaccid left hemiparesis. So what is the differential diagnosis of acute focal neurologic deficit? Well, that is actually a relatively short list with, of course, cerebrovascular disorder right there at the top, ischemia or hemorrhage. But the differential actually includes also seizures with postictal paralysis, hypoglycemia, brain neoplasms, demyelinating disorders such as multiple sclerosis, infections such as brain abscess, encephalitis, meningitis, and complicated migraine. Just to prove my point, on the right is the MRI of a patient who presented very similar to our patient, but was actually diagnosed with a tumor in the parieto-occipital region with quite a bit of subcortical white matter edema, was seen here in bright white. edema creates a hyperintense signal, and you can probably make out the isointense round mass in the middle. So what's the next best step in the management? Imagine the right MCA gets blocked, as pictured in this illustration. So almost immediately, some part of the brain, usually the deep structures which rely on that blood flow, die pretty quickly. And that's called the ischemic core. It is an area of the brain that suffered irreversible ischemic damage. However, there is a large part of the hemisphere that is surviving on blood flow from collaterals, and that is called ischemic penumbra. Collateral flow is not as robust as direct blood supply via the MCA. Think of it this way. If a main highway gets blocked by an accident, you can still get to your destination by side streets, but with much more difficulty. Penumbra can become viable tissue or permanent infarction. So the primary principle of acute stroke therapy is to reestablish blood flow before the brain infarcts. And the clock starts now. So our patient arrives at the hospital, and to facilitate stroke care, a stroke code is called. By the way, is scrub still a thing? Well, a stroke code brings the entire team together to the bedside. We usually want to know a brief history, what was the last time known normal, and contraindications to TPA. We need to get a quick neurological examination, sort of to get the lay of the land, and obtain imaging to rule out hemorrhage. And there's usually one person who is lost during the code, like Dr. Kelso here, who's asking for free muffins. National Institutes of Health Stroke Scale is a standardized focused neurological exam that was developed to be able to rapidly assess and follow a stroke patient. It consists of 11 domains: level of consciousness, orientation, command following, gaze, visual fields, facial palsy, motor strength of the extremities, limb ataxia, sensory loss, language, this is expressive language, dysarthria, articulation, extinction and inattention, which is essentially neglect. Now, the actual scoring is not as important as describing the deficits. Just note that the higher the score, the bigger the stroke. So NIH stroke scale of 0 may be normal or near normal patient. NIH stroke scale of 42 is a very severe stroke. Please note that gait and reflexes are missing from this list. NIH stroke scale does not replace a full neurological exam, but it allows you to examine and treat a patient faster. So let's get back to our case. Remember, our patient had dysarthria, profound neglect, anosognosia, right gaze deviation, left homonymous hemianopia, left facial droop, and flaccid left hemiparesis. So let's add up the score. For the level of consciousness, the person was normal, orientation was normal as well, and so was his command following. But on the gaze, he could not cross midline, forced gaze deviation, so he earned 2 points there. Visual fields, he had a partial field cut, 1 point. He had a partial or lower face facial palsy, 1 point. On motor strength of the arms and legs, essentially the right side was normal, so he received 0 points there, but the left arm and leg had no effort against gravity. It did have a twitch of movement, so he got a 3 for both out of a possible 4. Limb ataxia, there was no ataxia out of proportion to weakness. Sensory loss, it was pretty dense, so he earned 2 points there. His articulation was impaired, so he got 1 point, but he had no aphasia. He was able to express himself, 0 points there. And he had, of course, profound neglect, 2 points. So when you add up the entire score, it's about 15 points, which correlates with a large infarction. So far, so good. By the way, you're still on the clock, so don't think about pausing this presentation to go get some coffee. It's about to get more fun. To proceed to treatment, we first need to exclude intracerebral hemorrhage. And a non-contrast head CT is excellent for that purpose, with over 95% sensitivity. Let's take a moment to learn how to read CTs. So let's focus on the image on the left. Pretend the patient is lying in front of you on a table, with feet closer to your face and head further away from your face. The patient is lying face up. So you're looking at the patient's brain through the bottom of their jaw. So the eyes should be facing towards the top of the slide, and the patient's right side is on your left. The bright outer rim is the dense skull. Now look at this axial slice through the basal ganglia. Do you see anything abnormal? Is there a problem on the patient's right side? Is there a problem on the left side? Is there no problem? Well, if you said that this is a completely normal study, you are correct. But you say to yourself, how can the CT be normal? Isn't the patient having a stroke? In an acute ischemic stroke patient, early head CT is normal. Pause on that for a second. Ischemic neurons cannot maintain sodium-potassium gradients and as a result take on water, becoming edematous over a course of hours to days. Edema is fluid. Fluid looks dark or less dense on CT. So it typically takes about 6 hours for a CAT scan to develop a hypodensity corresponding to the ischemic tissue. Our patient presented within an hour after symptom onset, so his stroke has not yet set in. So a normal head CT does not mean no stroke, but instead it's actually reassuring and it's telling us there's brain left to save if we were to proceed to treatment. Oh, head CT, you sly devil, you won't trick us. By the way, take a look at the image on the right. There is a hyperdense region in the sylvian fissure. Do you know what that is? You're right, of course, it's blood, or clot to be more precise, that's contained within the middle cerebral artery. This is called a dense vessel sign. It's quite specific and very helpful when you see it, but it's not very sensitive. You can see these dense vessel signs in other vessels, not just the middle cerebral artery. So the head CT is the best initial test because it's very good at excluding hemorrhage, but should be completely normal in early ischemic stroke. With a head CT, we also typically get a CT angiogram. It's a pretty rapid study that follows a bolus of contrast to trace the lumen of head and neck cerebral vessels leading to the brain. It's an excellent study to document large vessel occlusion. On the left, you once again see the axial cut. The patient is looking towards the ceiling. You can actually see the eyeballs facing the ceiling. And on the right is the coronal cut, where the patient is actually facing you. So take a look at the image on the left. Do you see the robust flow in the left middle cerebral artery? Now compare that to the right. Something's missing, isn't it? There's a thrombus occluding flow through the right MCA. And the same can be visualized on the coronal cut. Now back to the case. Do you remember the primary goal of acute ischemic stroke treatment? That's right. Remove the obstruction and restore blood flow to save the ischemic penumbra. So, to recap, our patient was delivered by an ambulance to the hospital. His symptoms were recognized as a right MCA syndrome and a stroke code was called. A rapid neuroexam, the NIH stroke scale, defined his deficits, and CT confirmed absence of hemorrhage, and CTA confirmed right MCA occlusion. So the next step is treatment, administering IV TPA. In order to give TPA, the patient has to be within a 4.5-hour window, so establishing the time last known normal, or last known at baseline, is crucial here. We typically check a finger stick because hypoglycemia is a great mimicker of stroke. Elevated blood pressure is very common in stroke patients, and it's the single most significant risk factor for bleeding after TPA. So we have to lower the blood pressure to less than 185/105. The contraindications to TPA, by the way, can actually be summarized as 2 statements. Are you currently bleeding, or are you likely to bleed? So the head CT can exclude intracranial hemorrhage. But if there's acute internal bleeding, giving a thrombolytic that activates plasminogen and lyses clots is not a good idea. If a patient has a condition that predisposes them to bleeding, for example, full-dose anticoagulation, IV TPA is contraindicated as well. Please note that although labs are typically sent during the stroke code, we don't have to wait for results to treat the patient unless there's a history or suspicion of coagulopathy. So let's get back to our case. TPA was started, and neurological examination remains unchanged. So have we accomplished our primary goal? Well, obviously not. CTA told us there's an occlusion in the right MCA, and unfortunately TPA works about 1/3 of the time on a lesion like this. It's time to get a lot more aggressive. We review eligibility for endovascular, which in a nutshell means a previously functioning patient, now with disabling deficits, whose penumbra, or area at risk, and also the area that we can save, is nearly twice as large as the ischemic core, or area of irreversible damage. Our patient fits the criteria, and we prepare him for intervention. By 60 minutes from arrival to the emergency department, the patient's groin is punctured, a catheter is ascended through the femoral artery, up the aorta, brachiocephalic trunk, right CCA, right ICA, and eventually reaching the right MCA clot, and thrombectomy is performed and clot is removed using suction or one of these modern stent retrieval devices that's pictured on this slide. These therapies are actually pretty effective over 80% of the time. In fact, these are probably the most effective treatments in all of medicine, with a number needed to treat of 2 to 3 to help one patient achieve functional independence. That's pretty remarkable. Now, you've been paying attention, and I know what you're thinking. If thrombectomy is so wonderful and IVTPA doesn't always work, why not just skip IVTPA and go directly to thrombectomy? Valid question, my young Padawan. The problem is that even when the stars align, it takes 30 to 60 minutes to assemble the endovascular team and puncture the groin. Look at this time circle here. Also, about 1/5 of the patients may have difficult anatomy, making thrombectomy a nightmare. So IVTPA is always much faster and can continue to work while arrangements are being made for endovascular intervention. Remember, the ultimate goal is opening the blood vessel, so we don't wait at all after IVTPA before proceeding to thrombectomy. But say you're still not convinced. What difference does a 60 minutes make? Imagine you see our patient arriving at the ambulance bay in the emergency department. Well, in that second of right MCA occlusion, the patient has lost 32,000 neurons. You decide to introduce yourself. Hello, Mr. Smith, I'm Dr. Rybinnik. That little delay cost the patient 2 million neurons, so we really no longer introduce ourselves to the patient until the treatment's been started. If you wait an hour before beginning treatment, that patient will have lost 120 million neurons, which is equivalent to the same number of neurons a patient would lose with nearly 4 years of aging. And in an average stroke, a patient may lose over 1 billion neurons, so pretty much every second counts. While if graphs get you excited, this one illustrates the same point. This is data from Hermes collaboration, including modern endovascular thrombectomy trials. On the y-axis are the odds of patient improving, and on the x-axis is time from symptom onset to the start of intervention. The longer we wait, the less chance for improvement. And at around 7 hours from symptom onset, risk of thrombectomy begin to outweigh benefits. Remember the stroke neurologist mantra. Time is brain. Say it with me. Time is brain. Now, I did promise something cool. These are the images of a cerebral angiogram. Just to orient you, the patient's looking directly at you. The X-ray shadow in the middle of the screen is an endotracheal tube. The endovascular catheter is resting in the carotid artery, and the dye is injected, and X-ray images are obtained in rapid succession to track the flow of dye, and consequently the flow of blood in real time. So take a look. Do you see a problem? Just as we suspected, the right MCA is still occluded. Now, take a look at what happens after the clot's been removed. We have restoration of robust MCA flow, and if we keep scanning, we can even see the blood travel from the arterial phase across a capillary network into the venous sinuses and out of the cranium through jugular veins. Now, is this not the coolest thing you've ever seen? Take a look at the clot that's been removed. So let's get back to our case. Endovascular therapy was successful, and neurological improvement was noted after the procedure, and patient was admitted to the ICU. Now that the flow has been restored, what are the new goals of treatment? Once reperfusion has occurred, we are now focused on prevention of secondary injury. Remember that blood pressure is an important determinant of bleeding risk. While we generally want permissive hypertension in acute ischemic stroke, we must now lower the blood pressure to avoid post-reperfusion hemorrhage. Blood pressure targets post-intervention are a bit of an educated guess rounded out with some wild speculation. So post-TPA, the blood pressure goal is typically set at less than 180/105. If we manage to open a blood vessel and restore perfusion, the blood pressure goal becomes 140/160 systolic. Now, these patients, of course, must be closely observed in an ICU setting with frequent neurochecks. We typically use NIH stroke scale to reassess stroke patients and get worried if the score increases by 4 or more points. Multiple neuroprotectant trials failed in the early 2000s, and it was generally a disappointing decade in stroke research. So the best neuroprotectant we have so far is homeostasis, making sure hyperglycemia is corrected, fevers are addressed, and targeting normocapnia and normonatremia. On top of that, cerebral edema usually rears its ugly head and peaks over the course of 3 to 5 days, and at times it becomes so severe that it needs to be addressed. But once we get the patient over this acute period, the goal now becomes to prevent recurrence. And the gooey chocolate center of that goal is, of course, stroke workup. Now that brings us to a discussion of stroke workup, mechanisms, and prevention strategies. And to keep going with my chocolate metaphor, I'm going to borrow a phrase from Forrest Gump. My mama always said stroke was like a box of chocolates. You have to do an MRI, transesophageal echo, and mobile cardiac telemetry to know what you're going to get. So let me ask you a question. Why do we need to do a stroke workup? A study was never done to prove that doing all those tests improves outcomes in stroke patients. Well, to that I say there's no study on the effect of parachutes on mortality in patients skydiving at 13,000 feet. Are you going to stop using parachutes until such a study is done? As stroke neurologists, we sort of intuitively understand that stroke workup changes management. So the idea is that 3/4 of patients may be at low risk for recurrent stroke, but 1/4 may harbor a dangerous source of clots, which needs to be addressed more aggressively. So we absolutely must find the wolf among the sheep. So who remembers the Virchow's triad? Rudolf Ludwig Karl Virchow was a 19th century German physician, among other things, who proposed a simple idea that in order to form a thrombus, the body needs 3 conditions: abnormal stasis of blood, in the heart for example, increased clotting potential, and endothelial injury, or vessel wall injury. So in a nutshell, stroke risk comes from disorders of the heart, blood vessels, and blood itself. It's not rocket science. So to expand on Virchow's theory, ischemic stroke, the most common kind of stroke, may be caused by vessel disease, cardioembolism, rare causes such as hypercoagulability and genetic derangements, and in 1/3 of the patients, even after extensive stroke workup, we never prove a cause. And those are known as cryptogenic strokes, although recently they've been reclassified as embolic strokes of undetermined source because they look embolic. So let's tackle the thrombotic mechanisms first. Which patients get thrombotic strokes? Well, there's a common risk factor profile for both large vessel and small vessel strokes. A typical patient is older, has multiple vascular risk factors such as hypertension, diabetes, dyslipidemia, smoking. So a hypertensive patient, for example, is at risk for both small vessel and large vessel strokes. The key clinical differentiator between these subtypes requires an understanding of what's meant by large vessel and small vessel. Any ideas? Well, I'll give you a hint. Large vessels are the ones that have proper names: carotid artery, vertebral artery, proximal middle cerebral artery, etc. Small vessels are unnamed perforators coming off of those named large vessels. These small vessels supply subcortical structures like the basal ganglia, thalamus, pons, deep cerebellum. Take a look at this example of perforators off the MCA. So small vessel strokes tend to be radiographically smaller and subcortical, and clinically milder. By the way, what symptoms will you never see in a patient with small vessel subcortical stroke? It starts with a C and ends with aortical. That's right, small vessel lacunar strokes generally do not cause aphasia, neglect, field cut, which are symptoms traditionally attributed to the cortex. In order to call a stroke large vessel, we need to have radiographic confirmation of large vessel disease on vascular imaging. Take a look at this example. Carotid artery stenosis is the poster child for large vessel stroke. One more important point about large vessel strokes. Of all ischemic stroke mechanisms, this one is practically the exclusive cause of transient ischemic attacks. If you're interested in the mechanisms, large vessel strokes are typically caused by atherosclerosis, and lacunar strokes have multiple proposed mechanisms, including lipohalinosis, tiny atherosclerotic plaque in the perforator vessel, and microemboli. Can you guess what the CT is showing? Do you see the subcortical black holes corresponding to chronically damaged brain? What type of strokes are these? If you said small vessel, you are correct. These are small and subcortical and therefore by definition small vessel or lacunar infarcts. Now this stroke is more extensive. And take a look at this MR angiogram image of the common carotid artery, bifurcating into internal and external carotids. At the arrow, You can see the internal carotid artery, and it almost looks like as if someone took a bite out of the ICA, doesn't it? This is the classic appearance of a large vessel atherosclerotic plaque causing stenosis. Stenosis can result in poor cerebral blood flow, causing watershed strokes, like the ones pictured here, or pieces of the unstable plaque can embolize to the brain. Now, let's switch gears to discuss cardioembolic stroke. Clinically speaking, there is generally a striking difference between how cardioembolic and large vessel stroke presents. Think of it this way. How long does it take to form a carotid or MCA plaque significant enough to affect the blood flow? Months? Years? It's a slow process. In that time frame, the brain slowly adjusts by increasingly relying on collateral flow. If that stenosis progresses to the point of occlusion, the stroke will likely be relatively small since the brain has had a chance to adapt. Now imagine that a previously normal MCA suddenly gets occluded by an embolus. The entire MCA territory starves and the patient will have maximal severe deficits. Also, radiographically, cardioembolic strokes tend to be larger and may affect multiple vascular territories. Think shower of emboli. And high-risk embolic sources include atrial fibrillation, left atrial appendage or left ventricular thrombus, valvular disease such as endocarditis, structural heart disease, paradoxical embolism from the venous system, which typically goes to the right side of the heart, across a patent foramen ovale, which is a communication between two atria, to the systemic circulation, left side of the heart. Aortic arch plaque and cardiac tumors can also embolize, although that's more rare. So all of these can cause, cue cheesy animation, embolic strokes. So here's the imaging example of cardioembolic strokes. Multiple hyperintensities in both hemispheres correspond to acute stroke in various vascular distributions. So in this patient, transthoracic echocardiogram, shown here is the classical four-chamber view of the heart, showed a large left ventricular thrombus. Here are some of the more rare mechanisms of ischemic stroke. Arterial dissection is basically a tear of the intima and the media, resulting in hematoma forming to heal the tear. But occasionally, pieces of that hematoma can embolize to the brain in the process. Dissections usually happen in younger patients with predisposition, think connective tissue disorder and weakened vessel walls, and superimposed trauma. By the way, trauma doesn't necessarily mean a car accident where a person is thrown through the windshield. Trauma can be as mild as a violent sneeze or retching and vomiting. Think of the vessel wall as being Superman weakened by kryptonite, and Batman is mild trauma. So normally Batman has nothing on Superman, but in this situation Batman's punches can surely do some damage. Other causes include sickle cell disease, hypercoagulable states, vasculitis, vasospasm, possibly drug-induced, venous sinus thrombosis, this is a venous infarction, genetics such as mutations in proteins that ensure vessel integrity, and complicated migraine, which actually causes aligemia or decreased blood flow and sometimes can progress to an actual stroke. Well, that was a lot of information, but I know what you're thinking. Which stroke mechanisms are the most dangerous? Which ones do I really need to worry about? Well, that's a great question, and I'd like to illustrate that concept of ischemic stroke risk with dogs. Small vessel disease is like a small French bulldog, conferring a stroke risk of several % per year. Large vessel disease, well, here we're looking at a medium-sized border collie, 3 to 6% risk per year. Cardioembolic stroke is like a large German shepherd, stroke risk of up to 15% per year. And rare causes are kind of unpredictable, just like this kitten. Sometimes they have a low risk of stroke of less than 1%, and sometimes they can increase the risk of stroke tenfold. Depends on the cause. Now that we understand the possible causes of stroke, remember why we embarked on this discussion in the first place: to find the wolf among the sheep, a patient who is at high risk. So a typical stroke workup consists of a brain MRI without contrast, which is the gold standard. Depending on the clinical history and MRI, you can suspect a certain mechanism or mechanisms. Typically, you would also need to do vessel imaging. For cardioembolic workup, every stroke patient gets a transthoracic echo and an EKG, and some in-hospital telemetry cardiac monitoring. But if you truly suspect a cardioembolic source, you would need to go further to transesophageal echocardiogram and extended outpatient cardiac monitoring. Modifiable risk factors such as dyslipidemia, diabetes, and smoking should be assessed and addressed. In certain patients where a rare stroke mechanism is suspected, we may have to check for hypercoagulable state or genetic vasculopathies. And occasionally, invasive procedures like a cerebral angiogram, which is really the gold standard of vascular imaging, and a brain biopsy, which is the gold standard of gold standards, may be necessary for diagnosis. For example, if you have a case of CNS vasculitis. So the gold standard of acute ischemic stroke diagnosis is specifically diffusion-weighted imaging sequence on the MRI. Now, I'm not a radiologist. I just play one for the purpose of this podcast. DWI essentially shows area of energy failure when neurons can no longer maintain sodium-potassium gradient, and water does not diffuse along that gradient and creates a bright signal or an area of restricted diffusion. DWI becomes positive within the first 30 minutes and stays positive for approximately a month after the stroke onset. And in order to confirm true restriction of diffusion, DWI is checked against its evil twin, apparent diffusion coefficient, or ADC, pictured here on the right. True stroke is bright on DWI and dark on ADC. By the way, since MRI is quite a bit slower to acquire than CT, it's typically done after acute treatment to avoid delays. Our options for non-invasive vascular imaging are essentially CT angiogram and MR angiogram. You saw that our patient got a CTA during the stroke code, and here's another example. CTA is very quick. It has slightly better resolution than MRA, especially for distal small branches of cerebral blood vessels, but CTA is susceptible to bony artifacts, it requires radiation, and it carries a risk of contrast nephropathy. So CTA is perfect in a neurological emergency where you quickly need to know the vessel status. MRA, on the other hand, pictured on the left side of the slide, is slower but safer. It gives you a beautiful picture of proximal intracranial vessels without any contrast. So MRA is preferred in non-emergent situations and in patients who should not be repeatedly radiated. Think of kids, cancer patients, and pregnant women. They probably would rather avoid a CTA. Oh, and MRI doesn't image bone, so no bony artifacts. The third option for vascular imaging is ultrasound, specifically transcranial Doppler and carotid ultrasound combination. But that modality is best used for confirmation or follow-up of known lesions because it's operator dependent and it can only visualize certain portions of the vessels and not the whole vascular tree. This is MRA of the neck. The images take longer to acquire, and we have to use gadolinium contrast to avoid artifacts, but in return we get a beautiful picture of the vascular tree, all the way from the aortic arch to the brain. Do you remember us going over cerebral vasculature at the beginning of this talk? Well, this is that same view. The patient is still looking at you with the aortic arch all the way on the bottom, carotids and vertebrals in the middle, and circle of Willis towards the top. So compare that with a CTA on the right, which is a little more detailed, but it's definitely contaminated with bony artifacts and veins. Bottom line, there's no clearly better study, and each study has strengths suitable to certain use cases, like each member of the Avengers superhero team. Except Hawkeye. No one really knows how he's lasted this long battling gods and otherworldly beings with a bow and arrow. Is anybody else confused? Okay, that was a very long detour, but remember, we still have a patient to treat. So back to our case. CTA was done on admission and there was no carotid stenosis. Echo showed normal ejection fraction and mildly dilated left atrium. And telemetry monitoring showed paroxysmal atrial fibrillation. So what's the appropriate stroke prevention regimen? Before we jump into the prevention regimen, let me ask you a question. What do you think is the #1 risk factor for stroke in general? Did you say hypertension? What about #2 risk factor? Nope, still hypertension. What about #3? Still hypertension. Hypertension increases the ischemic stroke risk 4-fold and hemorrhagic stroke risk 9-fold. Then there are the other well-known vascular risk factors. So the 4 major pillars of stroke prevention include blood pressure control, statin therapy, not so much for the cholesterol, but it confers anti-inflammatory plaque stabilizing effects, antithrombotic therapy, which in our case is actually going to be an anticoagulant for atrial fibrillation, smoking cessation, and glycemic control in diabetics. Now, let's say we flip the script. While we were running around getting those CTs, CTAs, TPA, all the deficits in our patients miraculously resolve within 30 minutes. How does our management change? Well, first, we don't give TPA. It's hard to make somebody more normal than normal. The clock is reset, and this becomes the last known well time. So if the symptoms return within 4.5 hours, the patient can still be treated with TPA. And finally, the workup is the same as if the patient suffered a stroke. So let's talk about transient ischemic attack for a second. TIA has become sort of the wastebasket of medicine. Disorientation after opioids? TIA. Episode of slurred speech during dialysis? TIA. Transient sleepiness? TIA. Transient tingling? TIA. 60 seconds of word finding difficulty? TIA. Transient facial droop? Well, it's very easy to turn off our brains and call everything a TIA, but the vast majority of those events are not cerebrovascular in nature. A true transient ischemic attack is very worrisome. It's basically brain pain. It signals that a stroke is coming. Remember that earlier in this talk, we spoke about large vessel disease. Well, TIAs occur almost exclusively in patients with symptomatic large vessel disease, like carotid stenosis. If you don't identify the stenosis and address it, you may be dealing with a full-blown stroke pretty shortly. So in the modern era, a good definition of TIA can be found in something called the ABCD squared score. So a transient event is more likely to have been cerebrovascular if the patient is older, has risk factors such as hypertension and diabetes, if the symptom lasted 10 to 60 minutes, and preferably included unilateral weakness or speech disturbance. Well, that was a lot of information, I realize that. Let's rest your brain with this fun clip from the movie Dracula Dead and Loving It.
Gentlemen, you are about to observe your first autopsy. It is not unusual for some members of the freshman class to feel a bit faint during this procedure. So this is where we begin to separate our future physicians from those who just want to play doctor. Well, no one seems to be standing.
Hello, I'm still standing, Professor Van Helsing.
Why don't we have a look at the brain? Huh? Behold the naked human brain. Examine it. So, a good morning's work.
Whew. Well, that concludes the first 6 months of a vascular neurology fellowship. Hopefully you still feel confused, but like I said before, on the higher level about more important things. Now, let's switch gears and discuss hemorrhages. 59-year-old man with uncontrolled hypertension and frequent binge drinking was found by his wife on kitchen floor with left-sided weakness, headache, and lethargy after she heard him fall. There were no previous such episodes, family history is unremarkable, and just as before, our patient arrived to the hospital within 1 hour after last seen at baseline. In the emergency department, he vomited twice. On the neurological exam, the blood pressure is elevated, but our patient is still protecting his airway. He's lethargic, responds to voice, but disoriented when he's awake. There is no aphasia or neglect, but he does have moderate dysarthria, left facial droop, and flaccid left-sided weakness and numbness. So what's the next best step in the management? Well, stroke code, of course. We can't be confident whether this is ischemia or hemorrhage just on the basis of symptoms alone. Stroke code head CT was done. Can you see the abnormality? I bet you can see it halfway across the room. There's an acute left thalamic hemorrhage and some mass effect on the right lateral ventricle. So we talked about the primary goals in the management of ischemic stroke, but what about the primary goals in the management of hemorrhage? The early goal in the treatment of acute hemorrhage is preventing expansion and secondary injury, because that's most likely to kill our patient. Aggressive blood pressure control and reversal of coagulopathy are like Iron Man and Wonder Woman, very indispensable. Unlike ischemic stroke, where cerebral edema peaks at 3 to 5 days, hemorrhages create mass effect much faster, sometimes even within minutes, which we often need to address. Thankfully, this is not an issue in this case, so that's a nice cop-out for me to leave the management of cerebral edema and intracranial pressure to a whole different talk, except to say that the MISTI procedure is the most promising intervention, which we're going to talk about in the next slide. Homeostasis is just as important as in the management of ischemic stroke. And finally, the goal now becomes diagnosis and prevention of recurrence. So say you have controlled the hypertension, reversed the coagulopathy, and verified stability with a repeat head CT. That blood continues to sit in the brain for weeks, and iron within it is actually toxic to neurons and glia. So we intuitively believe that removing the blood should be beneficial, but invasive surgical procedures such as open craniotomy and evacuation of clot has not really improved outcomes, probably because of surgical trauma that's inflicted on the brain just trying to get to that hematoma. The most promising surgical procedure in recent years is the minimally invasive surgery with TPA for intracerebral hemorrhage, otherwise known as MISTI. A catheter is placed through a borehole directly inside the hematoma, and low doses of TPA, we're talking about 1 milligram or so, are used to dissolve and passively drain the hemorrhage out of the brain over a course of a couple of days. Now, I know what you're thinking. Am I crazy? Didn't I just say not to give TPA to hemorrhages? It used to be that a student would fail a rotation immediately for suggesting such an action, but it's a brave new world now. So as you can see, over the course of several days, the hemorrhage is drained out. As a result of this procedure, there's a dramatic reduction in the hematoma size and mass effect. So that brings us to a discussion of stroke workup, mechanisms, and prevention strategies. Charts and pictures coming right up. So hemorrhagic stroke is less common than ischemic stroke and includes bleeding in the brain parenchyma itself, or intracerebral hemorrhage, and bleeding just outside the brain in the subarachnoid space, or subarachnoid hemorrhage. Subarachnoid hemorrhage deserves a couple of its own slides, so we'll tackle that in a moment. Intercerebral hemorrhages are essentially classified by their location, deep versus lobar. Now, hemorrhagic transformation of ischemic stroke, while it's certainly considered under the umbrella of intracerebral hemorrhages, is basically a bleeding in the necrotic tissue. It's quite common and it doesn't really behave like spontaneous intracerebral hemorrhage. It's not likely to kill you, so we'll leave that out for now. Deep bleeds are the most common, and they're sort of analogous to the small vessel type of ischemic stroke. Only in this case, these fragile perforators rupture instead of occluding. So the most common location for these hemorrhages are basal ganglia, internal capsule, thalamus. This type of hemorrhage is actually often nicknamed hypertensive. Remember, because hypertension is the strongest risk factor for small vessel disease and actually increases the risk of such a hemorrhage 9-fold. Lobar hemorrhages, on the other hand, unfortunately have a variety of causes, ranging from vascular malformations, tumors, cerebral amyloid angiopathy. Does this look familiar? Looks quite a bit like ischemic stroke workup, doesn't it? We start with the MRI of the brain, but this time we use gadolinium. Gadolinium typically sits inside blood vessels, but does not enter the brain unless the blood-brain barrier is broken. So it's excellent for enhancing tumors, but MRI also includes a gradient echo or susceptibility weighted sequence to assess for other microhemorrhages. Microhemorrhages basically mean that the vessels are weak and are prone to rupture, a vasculopathy of sorts. So we also need to exclude vascular malformations, and for that we can use MRA or CTA of the head. In the cases where endocarditis is suspected, a thorough workup with a transesophageal echo and blood cultures is in order. Now, modifiable risk factors should be addressed, and in certain patients, we may even need to go further, performing genetic testing, angiograms, and even a brain biopsy. I gave you an example before of CNS vasculitis, which can cause hemorrhagic and ischemic strokes. Here's one example of a lobar hemorrhage, AVM. So typically, arteries communicate with veins via a capillary network, which slows down the blood and decreases the pressure. In an AVM, arterial pressure is directly transmitted to a vein, which is really not equipped to withstand it, and AVMs are prone to rupture and bleeding. Look at this slide here. You can see arteries and veins right next to one another. That should never happen. There should be a capillary network between them. So AVMs essentially appear like a tangle of vessels on a CTA. This particular AVM is probably fed by the MCA branches and drains into superior sagittal sinus. Here's yet another example of a cause of lobar hemorrhages. This is the gradient echo or GRE sequence of the MRI, and you're looking at different axial cuts on the same brain. It's especially good at detecting hemosiderin, which is a byproduct of blood, as you know. So here you can see a plethora, nay a multitude, nay a cornucopia of tiny subcortical and cortical microhemorrhages. These look like hypo-intense spots, but because we're in med school and need a $10 phrase that describes them, we call them areas of susceptibility. So this is the hallmark of cerebral amyloid angiopathy when it's seen in an elderly person who's also demented. Remember, amyloid, the same protein that can cause Alzheimer's disease by damaging neurons, can also damage the small blood vessels, causing them to be brittle and bleed. So now that you understand the differential diagnosis, what is the mechanism of our patient's hemorrhage? Think about it. You're absolutely right. His hemorrhage is due to small vessel disease or hypertensive. So back to our case. MRI of the brain with gadolinium showed no evidence of neoplasm. The GRE sequence of the MRI showed no other microhemorrhages, so we're not thinking CAA. CTA of the head was negative for vascular malformation. The final diagnosis in this case is hypertensive right basal ganglia bleed, also known as small vessel disease. And patient was discharged to rehab with a blood pressure of 125/70. So just like with ischemic stroke, you're probably thinking, which of the hemorrhage mechanisms are more dangerous? So I'd like to illustrate the concept of hemorrhagic stroke risk with cats. Small vessel disease is like a lynx. Dangerous but relatively small risk of recurrence. Now lobar hemorrhages, on the other hand, carry a much higher recurrence risk. Now that line is pretty hard to miss, so we can probably run away in time, but he can still bite us if we don't treat him appropriately. We are coming to the end of our journey together. In the next few slides, let's talk about subarachnoid hemorrhage. Quick refresher, by the way. Subarachnoid space is located between the pia and the arachnoid. The important point is that blood vessels and cranial nerves run through this space bathed by CSF. All caught up? Great. Now, when a vessel ruptures in the subarachnoid space, the blood mixes with CSF and causes chemical meningitis, which in turn causes the typical symptoms: worst headache of life, neck stiffness, lethargy, nausea, vomiting. By the way, subarachnoid hemorrhage does not have the market cornered on worst headache of life. Can you think of any other disease processes that can cause thunderclap headache? That's going to be your homework for today. Let's get on to the causes. Trauma is actually the most common cause of subarachnoid hemorrhage, but ruptured saccular aneurysms are the most common cause of non-traumatic SAH. Now, these occur at the branch points in the circle of Willis, where the hemodynamic stresses of turbulent blood flow are the greatest. Makes perfect sense. Vascular malformations, such as the AVMs we discussed, can also rupture into the subarachnoid space. So the three feared complications of aneurysmal subarachnoid hemorrhage are rebleeding, especially in the first 24 to 48 hours, obstructive hydrocephalus caused by clotting blood, and vasospasm caused by chemical meningitis. By the way, vasospasm risk tends to peak around the first week, but can last for as long as 20 days. So subarachnoid patients may be in the hospital for a long time after their aneurysm has been fixed. Here is an example of subarachnoid hemorrhage on a non-contrast head CT. You should be a professional by now. You know that you're looking up through the jaw of the patient, the eyeballs are pointing up to the ceiling, and the patient's right is on your left. These are two different axial slices from the same patient. On the left is a slice through the basal ganglia, and on the right, it's through the midbrain. How should the sulci look? If you direct your attention to the ventricles, you can see that CSF is very hypodense or dark, so the sulci, which are bathed by CSF, should also be hypodense. Can you see the abnormalities now? All of the sulci are actually hyperdense because they're filled with blood. It's as if every crevice of the brain has been outlined by chalk. Hopefully, the treatment approach should be familiar at this point. The early goal in the treatment of acute aneurysmal SAH is basically preventing rebleeding and secondary injury. Presumably, a non-invasive vascular imaging study like CTA will already have been done to diagnose the aneurysm. Early aggressive blood pressure control and reversal of coagulopathy is still the key, just like in any hemorrhage. And then you need to direct your energy to securing that aneurysm early. Once the aneurysm is secured, the patient should be on hydrocephalus and vasospasm watch. Occasionally, subarachnoid hemorrhage is so severe that the obstructive hydrocephalus may need to be addressed early. For that, we have to make a burr hole in the skull and place an external ventricular drain that does exactly what the name suggests, diverts CSF flow from the ventricle outside to kind of circumvent the obstruction. For the prevention of vasospasm, the patient is treated with calcium channel blocker and imodipine, but if that fails, the patient may need to be treated with intraarterial, that is through the angiogram, or intrathecal, inside the ventricle, infusion of calcium channel blocker. Finally, prevention is extremely important. Even in our day and age, 1/4 of the patients die en route to the hospital. So once you've treated a patient with subarachnoid hemorrhage, you definitely don't want to see that patient go through this again. Smoking must absolutely be stopped. There's actually increasing data that aneurysms are not just the product of hemodynamic stress, but actually have inflammation in their domes, inflammation that aspirin may be able to mitigate, so it might be a good idea to treat these people with aspirin as well. Also, don't forget the surveillance and repair of other unruptured aneurysms whenever appropriate. So congratulations, you made it to the end of the talk. I realize that you're probably feeling information overload at this point. Here are some takeaway points of how to become a stroke neurologist. So remember your anterior versus posterior circulation, and remember the deficits that correspond to different vascular territories. Remember that acute ischemic stroke is a neurological emergency. We have to call a stroke code. Time is brain, so we are focused on rapid diagnosis and treatment with intravenous TPA and endovascular thrombectomy. Ischemic stroke workup is really necessary to find the wolf among the sheep and to decide how to properly prevent stroke in patients. Cardioembolic stroke has the highest risk of stroke recurrence. It's the large German shepherd of strokes. And also don't forget that Mel Brooks is an awesome writer, and you should definitely see all of his movies. Now, on the hemorrhagic front, acute hemorrhagic stroke is also a neurologic emergency, obviously. You have to treat aggressively, but in this case, we're trying to prevent rebleeding or expansion, so we need to reduce the blood pressure and reverse coagulopathy. MISTY is shaping up to be a promising surgical procedure for evacuating intraparenchymal hematomas to prevent secondary injury. Aneurysms need to be secured early, and patients should be monitored for vasospasm and obstructive hydrocephalus. And hemorrhagic stroke workup is necessary for effective secondary prevention of bleeds. Lobar hemorrhages typically have the highest risk of bleed. It's the lion in the room. Thank you for your kind attention, and as always, please let me know how I can make this talk better.